Integration continues to be the focal point for health and care. For the NHS, their long-term plan predominantly focuses around integration of health and care services and predominantly looking at how we tackle the challenges of moving acute demand out of hospitals into the community. The long-term plan recognises the role of local government in promoting well-being, independence and health, but it is primarily an NHS plan. So in the context of not having the social care green paper, this leaves a strategy gap for the long-term funding for social care, and in particular, how we will deal with the demand that moves from those acute hospitals into the community. The journey of integration hasn't been without its issues, and I'm sure many of you will be familiar with the 2017 King's Fund report, NAO report, that identified that actually there was limited evidence around the benefits of integration, particularly when it came to reducing demand for acute hospitals or for any financial purposes. Local government and the leaders in local government have been stepping up to this challenge, and recently a report by the by the King's Fund recognised the increasing role of local government in tackling these issues, and in particular the distinctive role in defining place, and particularly in the formation of the new ICSs. The LGA recent report, What a Difference a Place Makes, also recognised the increasing role of health and wellbeing boards, particularly in defining local integration narratives. So while there has been progress since 2017, and I believe the evidence is starting to show that we are making progress in this field, the challenges are still out there. At a national level, we still have issues of funding and eligibility for services. At a local level, there's issues around how do we form these new organisations and what does it mean to form these integrated care systems. And then at a frontline level, we still have issues of how do we get multidisciplinary teams to work together and overcome issues of professional relationships and professional boundaries. So in light of these challenges, and with the ongoing narrative, two questions come to mind. The first is, what do we mean by integration? What is its purpose? What are we trying to deliver? Why do we do it? The second is, if we believe in those things, what do we need to do in order to get there? And how do we make sure we focus on the priority items? During the course of our work, we've conducted thousands, if not tens of thousands, of case review exercises. Now, these are retrospective reviews of real people who've gone through health and care systems, conducted with the practitioners who are involved in their care. And while it does benefit from hindsight, it gives us an insight into how the systems are set up and configured to meet the needs of the people who go through them. And this is just one case example of the tens of thousands we've looked at. So Mike, and Mike's story, is not an uncommon one. In fact, it's probably representative of what we see. So Mike is 89, he lives at home, he's fully independent, but he trips and falls. He calls 999 and he's conveyed to A&E. He's initially found to have no serious injuries, but the decision's made to keep him in overnight for observation. It takes 3 days to coordinate his tests and to get all the results back. And though it's found he's had no serious or lasting damage, it actually takes a further 13 days to start coordinating his care package. During that time, he starts to lose mobility, more people become involved in his care, days turn into weeks, and eventually Mike ends up being discharged into a residential placement. Now, we reviewed this case through one of the case review exercises that we conduct, and the OT who was actually involved in his case at the time reviewed this and said, actually, that wasn't the ideal outcome, that wasn't the best outcome we could have achieved for Mike. And actually, in discussion with the other people reviewing that case, they all agreed that in this case, the system hadn't supported us to deliver the most independent outcome that Mike could have had. Now, when we come to the first question, what is integration? In my opinion, it has to be around delivering better, more cost-effective, joined-up outcomes for people like Mike. So I mentioned our national work. I've been involved in a number of pieces, but there's two that we want to call out today. So the first piece of work was commissioned in 2016 by the LGA. It was catchily titled Efficiency Opportunities Through Integration in Health and Social Care. The second piece was actually co-commissioned, so we've integrated our research here, which is quite nice, but co-commissioned across local government and health, and particularly to focus in delayed transfers of care and what's causing people to remain in hospital when they don't need to be there. And I think it's worth reflecting on the finding of these two pieces of work because it further brings home why we need to integrate and what we're aiming to achieve. So the first piece of work, the 2016 work, involved review of health and care systems, 5 health and care systems across the country. And as part of this, we conducted case review exercises similar to the one that I'd previously described. Now, there's a number of findings that I think are worth calling out through this. So first and foremost is the number at the bottom. So when reviewing real cases across 5 systems with the practitioners involved in the care of those individuals, we found that in 45% of cases, the outcomes and the pathway decisions we were making for individuals weren't the right ones. More specifically, when we look at different parts of the pathway, when we review people attending and getting admitted into acute hospitals, it was found, with hindsight, by practitioners involved in the care, that 26% of people entering hospital didn't need to go in. And actually, if we'd responded differently on the day or in the care leading up to that point, that acute admission could have been avoided. Further, when we look at the discharge decisions, we found that 24% of people leaving hospital were ending up in the wrong setting and could have had more independent outcomes. And then when we look at the long-term care that people receive, almost 60% of people going into residential care homes was felt by practitioners that could have been avoided. Now, Mike's story was just one, but what we found through this is that for 60% of people in residential care homes, they have stories similar to Mike. Our 2018 work then led us on to study 10% of the acute beds nationally. So we worked with 9 of the most challenged systems across the country on their detox measures to understand, with practitioners on wards, both health and care, what were people in those acute beds for? Did they need to be there? If they didn't need to be there, where could they be, and what was stopping them? So in reviewing over those 10,000 beds, we built up quite a detailed picture of how we're managing demand across health and care and acute beds and in the community. And what we found was that in 27% of cases, so 27% of people in acute hospital beds, they don't actually need to be there, and their care could be better met in the community. What's more, when we asked where those individuals could have ended up and what the best setting would have been to meet their needs out in the community, we found a big disparity between what actually happened and where those individuals ideally would have gone in the best case. And actually, in 42% of the case, we found that people were being discharged into settings that weren't well matched to their needs. And consistent with the 2016 findings, what we found is a significant potential reduction in people being admitted into residential placements and a requirement for more care at home and better capacity and quality of reabling services. Now, what was interesting, so in the 5 systems we reviewed in 2016, in the 9 systems we reviewed in 2018, and in all our other work up and down the country, all those systems are aware of the challenges that we face and those pressures and those stories like Mike's that I called out, and all are doing things to try and integrate health and care. We've got the formation of integrated care systems, we've got pooled funding arrangements through Section 75, we've got multidisciplinary teams being formed. But we still face the challenges and the results, like those stories of Mike's and the thousands other that I mentioned there. And what that led us to is the conclusion that it's not necessarily what you do, but it's how you do it that's important, and it's how you bring these services together and overcome some of those softer barriers and boundaries that we see. And so that leads us to our second question. What do you need to do in order to integrate? Many of the systems that we work with approach integration from a top-down approach. What I mean by that is we focus on forming of new structures, creating those new structures and filling them with roles, normally from the existing system, and getting those new organizations to operate, usually in shadow form, as they try and wrestle off responsibility from the existing organizations, and then ultimately co-locating teams. So we have healthcare practitioners sat next to social care practitioners to deliver care. Unfortunately, all too often, those co-located teams, though, don't actually deliver benefit and outcomes for the people who we need to serve, nor do they deliver benefits to staff. And actually, in 2016, one of those systems that we studied had gone to great lengths to bring together their health and social care teams. But when we looked at the outcomes being achieved, they were much the same to all the other systems. And when we looked at how those practitioners were spending their time, they spent no more time co-working on cases than they did when they worked independently in different offices. Now, it's important at this stage to say that I'm not downplaying or belittling top-down integration. It absolutely has to happen, and it cuts right to the core of the integration challenge and how we bring together 2 different organizations with 2 different sets of legal responsibility and 2 different funding arrangements. But the question for me is, how do we do that in a way that supports delivering those outcomes and improved outcomes for people like Mike? And how do they embed, build, and sustain those operational and outcomes changes that we need to deliver in order to make integration work? And so I propose, therefore, that we need to think about the problem the other way around. and start with the outcomes and start with the stories like Mike's and ask how do we start to make changes for those individuals in the system and then build the governance process, systems and finances around that to make sure it's sustained. In our experience, starting with that data capture exercise, so those case review exercises that I mentioned previously, and starting to truly understand the narrative and the stories of the people flowing through the systems is a good starting point. And starting to build up the opportunities and understanding of what needs to change really sets the direction of travel for future structures and organizations. The next step, though, is really building a rigorous measurement of performance and understanding of the outcomes we're achieving, and reporting that on a live basis, meaning that we can actually start to see the outcomes change as we happen, and every time we make a change, we can see the improvement that it's had. Using that to then empower the front line, the people who work with the service users, the patients on a day-in, day-out basis, and communicate with the communities and systems in which they work to start to live test and design new ways of working is a powerful way to start seeing the outcomes improvements come through. And if that performance measuring is in place and we start to see the outcomes being delivered, it then becomes much easier to implement the new structures, the new finances, and the new organizations. And by leading with the outcomes, we move away from narratives and challenges like, is this local government trying to bail out health, or is this health trying to take over, and move more to narratives around how do we do the right thing for people like Mike. What we've also found through the course of our work and through taking this outcomes-led approach is that integration doesn't necessarily have to be structural, and that we don't need to start at the top right of this picture. And in fact, integration can be multi-layered. And actually, there is a lot of headway we can make towards improving outcomes just by communicating about the capacity of services we have, about how things are working on the ground, and how we better deliver care. Or how we coordinate so that we don't end up with the nurse stood outside someone's house while we have the reablement worker in there delivering care at that time. And ultimately how we collaborate and start to make those multidisciplinary teams actually work on the ground. So I've talked a lot about the theory there and the national level findings. What we want to move now is to some practical examples around systems where we're actually working and taking this outcomes-focused approach to delivering integration. As I mentioned, we work up and down the country to deliver sustainable outcomes improvements for our clients. And that outcomes improvement is so fundamental to the work that we do that we put 100% of our fee at risk against delivering it. And it's that outcomes-focused approach that as health and care integration narrative builds has led to a number of systems pulling on us for support in this area. So first of all, I'm going to hand over to Peter from Essex to talk you through the work that's been going on there.
Good afternoon, conference. As Richard said, I'm here from the county of Essex, and I'm going to talk a little bit about the work that we're doing with health partners. My day job is the Director for Health and Social Care Integration within adult social care. As you can see from the slide, Essex is a pretty big and complicated place. We work with 5 clinical commissioning groups, 5 hospitals, 5 community providers. I think we're the only local authority area in the entire country that has been put within 3 NHS Sustainability and Transformation Partnerships. And if you add primary care networks onto that slide as well, you have a lot of lines on the map. I think if Essex was a famous painting, it would probably be a cross between a Pablo Picasso and a Jackson Pollock. It's a complicated situation. Although my day job is to lead integration with partners, I see it very much as around facilitating it, though. I'm not a disciple of integration. Integration is not the answer to everything. It is a means to an end. And certainly I think we should only be pursuing integration if we've got good relationships and if we've got good agreement on the outcomes that we want to achieve. And in a county the size of Essex, there's no shame in admitting actually that some of our relationships with some partners will be better than with others. That's no problem as long as we look to move at the pace of the fastest rather than the pace of the slowest. Over the last couple of years, we have made some good progress in Essex. Our relationships have massively improved with our health partners, as evidenced in a recent LGA peer review. The County Council is now seen as a constructive and collaborative partner, and we're starting to do some good business with our health partners. We've significantly reduced by 70% our social care delays, and we've also significantly reduced over the last 3 years permanent admissions into residential and nursing homes as well. In many parts of our county, we've established multidisciplinary neighbourhood teams where we bring our social workers with GPs and other professionals in neighbourhoods of 30 to 50,000. And we did that before the primary care networks were set up. We've also transformed North East Essex, which historically has been our most troubled part of the system, into now what is our best part of the Essex health system. And indeed, North East Essex is part of one of the 14 leading integrating care systems in the country. So we're proud of what we've achieved. But we know also that we need to go further. Not necessarily, I think, in terms of integrated care structures and organisations. Personally, I actually have little belief or faith that structures make that much difference. I think we can probably make any structure kind of work. But I do believe, picking up on what Richard said about starting with outcomes, there is definitely a lot further that we can go on outcomes. There's further that we can go in Essex to scale up good practice and to share learning. And there's further that we can do to determine and define what integration actually means on the ground for our workforce. There is absolutely, in my view, 100% no point being integrated right at the top if you're not joined up on the ground where actual decisions are being taken about people's care and support needs. That, to me, would be a bit like a military general playing around with some imaginary troops. So it's absolutely critical that we build integration bottom up. So as Richard said, recently we have commissioned a system diagnostic, working with all of those health partners that I showed on the first slide, to look at whether we are achieving the best outcomes always. We know that our hospitals are under pressure with very big increases in admissions. We know that the social care system is under pressure, and we know that there are pressures on our intermediate care. So over the last 3 to 4 months, we've been working with partners. We have reviewed over 2,000 beds in Essex hospitals. We've case reviewed over 350 cases and outcomes for people. And we've crunched through over 2 million sets of data points to see what happens to somebody when they go into a care setting and what happens afterwards. And these are some of the highlights that we found. 44% of people coming out of a hospital are not achieving the ideal outcome. For many of those people, to pick up the example of Mike, which wasn't from Essex, but could easily have been, an example like that where somebody has ended up in a residential care setting or a long-term care setting, whereas actually the ideal outcome and achievable outcome could have been at home. We've seen that there is variation in the effectiveness of intermediate care services provided by different providers. So some of those intermediate care services, these are designed to be short-term care. Some of those services are being really effective at reducing ongoing levels of need, but other services are being less effective. Now, if we could reduce that variation, we could reduce ongoing need by 33%, by a third. And we can also see that there's a number of people every day occupying hospital beds that don't need to be there. So we've got the findings. It's now the question of what next. We're now starting a process with all of our health partners, working within different geographies. So we know that actually, because of the size of Essex and the numbers of partners, there isn't going to be one single solution that we can just roll out across Essex. So we have to work with the partners that we've got. So we're now starting the process of planning. We're looking to align our strategies and actions to address the issues that this finding has shown. Some of the actions will be for the County Council to address on our own. Some will be for the NHS to address on their own. But we know that the biggest benefit, the biggest gain, will be if we align the timing and sequencing of those actions. And that brings me to my final point, actually, which I think the big game changer is not integration at all, actually. I think it is collaboration. Integration, frankly, if we really want to do it, could be achieved by force. It could be. It could be legislated for, it could be achieved by force. But that wouldn't actually address the underlying culture. Integration, I find, can often be deemed as a threatening term. It can be seen as merger, takeover. It can be even interpreted as submission of local authority under NHS or even vice versa. For me, collaboration is far more important. Collaboration is actually much more enduring. It's about a culture and a way of working, and it's about recognizing that different organizations, local government and NHS, have different strengths and different perspectives to bring to the party. So that's what we're trying to achieve in Essex. That's my personal ambition, is to try and achieve a more collaborative way of working between local authorities and health, not necessarily cleaner structures on a slide, which might help us interpret the system better, but actually might not lead to any better outcomes. So that's about Essex. I'm now going to hand over to Andy, who's going to talk about the work that Newton Europe have been doing in Birmingham.
Thanks, Peter. So I'm Andy Lum, and the reason why I wanted to spend 5 or 10 minutes talking about Birmingham, which it's not gone unnoticed, that's obviously not a county, is that I've been there since the end of 2017, and I've been working specifically with the chief executives across their system, which comprises of one very large acute trust that was formerly a few acute trusts. They've gone through their own integration just recently. There's a community trust, there's obviously a city council, and then there's a mental health trust, as well as a number of other organisations. So I can't compete with your slide, Peter, but it's definitely had its complexities as well. The population is about 1.2 million up in Birmingham, and their journey started very similar to how Peter's described his, and with a combination of the Newton assessment in the first instance, which provided very similar results to what Peter's described, and then there was a CQC system-wide review, which illustrated some very damning points on the system, including a quote which was letting the people of Birmingham down. I wanted to share, and it'll be a theme of what I'll certainly talk through, I wanted to share a practical kind of look at what's happened in Birmingham. So I'm definitely going to be in the detail as I talk this through. And this is a timeline of what we've experienced in Birmingham since we started over on that left-hand side with that CQC review and the Newton assessment. And the reason why I thought it was helpful, I hope, to show it like this is because there's a combination of the bottom-up approach that Rich has talked about, and also the top-down as well. So if you take, for example, in the early days where there was some operational governance established, there was a specific group for finance and performance that was established, and then there was the new model of care was designed. That felt much more like bottom-up in comparison to top-down. But as you start to move across and you reach the kind of the point at the end of the design and the testing, towards the point where the business cases needed to go in across the whole system to say, you know, is this what we're committed to? Is this what we're signing up to? That definitely started to turn more to top-down. And indeed, when you start to move all the way across and some of the rollout, which I'll talk in a little bit more detail to show you some of those results, started to come through, we're at the point now around about here where we're completing some of that and moving into the period where we have actually needed to move, Peter, to your point, from the point of kind of collaboration slightly more into integration. This is necessary, at least in Birmingham, because it was important to kind of formalize some of those informal structures that were created up until this point in terms of staff being in the right teams, the right employers, having the right contracts, and also some of the actions around getting IT involved and doing installations and even just getting proper property for these new teams to sit in. One of my first points was over on the left-hand side of my timeline was a vision and a strategy, and I think that we can't kind of underplay this enough. This is a critical, and was for Birmingham, an absolutely critical starting point for the work that they did. And their vision and strategy, at least, was formed of these three components. The red part, very much about the upfront kind of universal well-being offer. The green part, which was called early intervention, is essentially urgent and emergency intermediate care. And then the blue section is much more about that kind of ongoing, that personalised support that Birmingham's able to help people with. The segment that we were contributing to was the green part, early intervention. A silly anecdote, but useful nonetheless. In the early days when the vision was put together, It wasn't put together with as much involvement from the GP community as everyone thought it should be. And as soon as the GPs got involved and took one look at early intervention, they said, yeah, that means something completely different to us. So getting the vision right in the early days and involving all of the partners from across the system, we've certainly learned is an absolutely critical starting point. One of the first tasks that was done was actually bringing together 28 people from across the system. These were frontline and kind of middle management workers. This is a photo from one of the sessions, and we armed them with the Newton assessment that we did, which gave some of that evidence that Peter's touched on, and really went quite deep on the root cause of what some of the challenges were. And we also gave them some principles around kind of urgent and intermediate care for Birmingham. And the combination of those two things together meant that they were able to very successfully set the programme off in the right direction by articulating what experience do we need the citizens of Birmingham to have in order to get the best possible outcomes. And then as a consequence of that, what's the environment that staff need to be in order to deliver it. That was an essential starting point, and it united the individual organisations very successfully who had previously been wrestling with different numbers and arguing about where fault lied. But again, it's the Mike story, uniting people around the people we're looking after and the outcomes. The other thing that Birmingham did, which was very successful, and the key part as well of sustainability, is that we located these 8 people. We had about 75 applications for these 8 roles. They're improvement managers. Newton trained them on some of the kind of the basic core methodology and analysis that was required. And these 8 people for the last 12 months have been spread across the Birmingham system, doing the type of work that Newton does in the front line, working alongside staff to help them change some of the decisions they're taking and use the data in order to inform it slightly better. And then it wasn't until the very beginning of this year, January, February time, where those 28 people, they looked at where specifically in the system the staff needed to head and which locations they needed to head for in order to begin to create an integrated health and social care service for older people in Birmingham. And in fact, there were 5 sites that were chosen, from activity happening at the front door of the hospital and the back door of the hospital, because obviously they're key decision points, through to a brand new community team. Birmingham had a little bit of catching up to do there, and also critically in the mental health wards as well. Just to share some very practical kind of real-life examples of what then happened. One of the first test sites was the activity happening at the front door of the hospital. And before we got involved, that was a group of staff, combination of therapists and nurses, whose job it was simply to make sure that they were stopping people coming in to the front door of the hospital and looking after them in alternative ways that were much better suited to their needs than a ward on a hospital. One of the things that we did is we injected some different data into this team, and we also introduced social workers into the team. And that's what made all the difference for this group. And over the course of the testing period that we were with them, which is it's about 3 or 4 months, they went from a position of helping about 2,500 people, older people, not come into wards in the hospital, going up by about 1,000 people, this is per year. And then the potential, which is the what else they can achieve now past what they've already been able to achieve, is looking up to about 5,500. And they'll be tracking up that number probably by about the end of December of this year. So in total, that activity has been probably about 6 or 7 months long to essentially double the number of people that are being looked after in a different way. The second area was then at the back door. So as someone has come out of a ward and is on their way out of the hospital, they were working from a position where essentially at that point where the ward says you're good to go, it was then taking about 12 more days in Birmingham for an older person to actually get out the hospital to the place that they needed to go. That's now down to 9, and in fact there's an extra day or so that can come off that. And one of the key parts of the success there, which speaks directly to Rich's explanation earlier of where we're sending these people, was that now 67% of them are actually going straight home, and therefore that home pathway we're able to access much more effectively than the high-intensity residential and nursing placements. Just at this point, I just thought you might like to see kind of how we've responded to the staff on the front line. So the work that we do, at least, we're constantly, well, we sit alongside the staff on the front line, and we're constantly measuring kind of what their views are on the activity that's taking place. So given that this was a couple of weeks into rolling activity out at the back door, so we've got new teams working together for the first time, but we were still pleased to see that we've got people talking about how much they love the changes. Thank you, it's really proving to be beneficial and efficient for patients. And overall, this is a much better way of working. And we're quite keen and to constantly kind of analyse what the frontline staff are doing and thinking about these changes along the way, because it's frontline led, and therefore it's really important that we understand that very clearly. And then that's supported then by data. And the most important thing which is worth pointing out on this is that this is the average cost of the ongoing care once someone came out of a hospital. So you can see in Birmingham that we were looking at, to begin with, around £190 for the weekly ongoing cost. And this green line here starts to track down, which is the 4-week moving average, because of this point where we introduced specific changes. So it started to take a dip, and that was just in Edgbaston, a small pilot area, and then we moved out across a wider pilot area around this time, and that's brought it down even further. So overall, those changes which the frontline are designing have brought down average ongoing weekly costs of care by 16% in the time that we've been with them. The third area was very, very new to Birmingham. They previously had some community services provided by the Community Trust and obviously the council as well. But those services were provided in a very fragmented way. So one of the tasks that we got stuck into was bringing those people together, and this for me certainly has been the kind of the epitome of that multidisciplinary team working in particular, because it's completely new. Here's the photo of the team, and they came together on their very first day together, most of them not knowing who one another are. And their role was to essentially, once someone's discharged from the hospital or the front door team have said, we can look after you in a different way, this team got straight into those people's houses, did that assessment in a multidisciplinary team, so that's a therapist, a social worker, and a nurse. And as a consequence of that, they are now, 3 or 4 months later, reducing the care calls per person per day by about 2 care calls. We also check constantly through our colleagues at Health Watch and also directly with residents about how they're feeling about the service, and that was very highly satisfied. And also the average time that they're on the service, which is definitely not yet where it needs to be. So the team are still spending about 30 days on average per person, looking after them, getting them to that point of independence, and that can certainly come down. But I remember when this team was first set up, and I fortuitously was in the office when they first came back from their first assessment. It was a great day for the team. They'd got the phone call from the Queen Elizabeth Hospital, and the gentleman had gone out at about 12 o'clock. They were in his house at about 1:30, and that was the therapist, the social worker, and the advanced nurse practitioner. And then no more than about an hour and a half later, they came back to the office, and I was sat listening to them, which was a mix of good and bad news. So I overheard them kind of discussing this gentleman's case. This gentleman then got kind of 3 times the amount of care that he needed to get from these 3 practitioners. So be under no illusion, putting people together does not spontaneously create multidisciplinary teams. So this gentleman was the most well looked after person in Birmingham at the time. But I think it just illustrates the kind of the challenges that probably, Peter, to your point, yeah, this kind of the structural side of things is not enough. It's the activity that you do and help the frontline teams kind of work through. What was, however, lovely was that 2 hours later, one of them then got back in their car, went back to the gentleman's house with the equipment that he needed, and he's stayed at home ever since, and he's now totally independent of any health and social care. And in fact, now this team achieve that 70% of the people that this team see are now completely independent of any social care or health needs. And then my fourth test area was over in the intermediate beds. This was a really, really interesting story because you'll notice here the length of stay before we turned up was about 45 days, and it's now actually gone higher. And there's a potential for it to go lower. I've noticed a lot of systems talk around sort of 28, 30 days for this length of stay. I think this was a big learning for the Birmingham system because of the previous work, we essentially changed the level of acuity that people were able to be looked after kind of in their own homes or out in the community. And the consequence, therefore, is that for some of those elderly citizens that were going into intermediate beds, actually they really needed some quite intensive care, and therefore that length of stay went up. And this was important for the council because I remember being in some of the meetings when we were looking at the number of intermediate beds that the council had across Birmingham, and they were basing it on a 28-day length of stay, which was some way off the mark. So doing those calculations and getting clarity on that is really important if you change that sort of level of acuity as dramatically as this. And then, of course, the number of people going home, the team are doing a great job continuing to bring that up. And my final area is over in mental health and the work that we did on the wards, which may seem slightly modest by comparison to some of the other areas, but nonetheless absolutely critical. Again, putting the social worker in the right team, in the right place, and helping them work really effectively with the right data alongside the mental health workers was absolutely critical. As a consequence of that, we reduced significantly the amount of time that people were waiting for kind of active treatment. And of course, if you do that, and therefore increase the amount of active treatment that someone's getting on the ward, you get them out of the ward much quicker. The reason why I wanted you to see this is because the detail is not important. It's the general colours and shape which hopefully illustrate the journey that Birmingham have been on. So before we started working with Birmingham over on this side, there were a significant number of people going to the very high-intensity nursing residential care homes, and down here, very, very few people going directly home with no support. This big green band is the key bit for the councils because that's all the people going home with packages of care. And indeed, unfortunately in Birmingham, not other services which may reduce the packages of care. I'm afraid they were getting more and more expensive. And then at the point where some of the changes kicked in, the ones I've talked about at the front door, the back door, the new community team, the mental health wards, essentially that whole picture has changed over time. And this green patch through the middle of the packages of care for people in their houses has got smaller and smaller and has been replaced with the dark green, which is the new community team. And remember, 70% of the people in the dark green go home completely independent of any health and social care needs. And then the light green at the bottom are just people just going home with nothing. So it's completely changed the kind of the acuity of how people have been looked after in Birmingham. And in fact, the yellow at the top is an illustration of some of those intermediate beds because we're able to look after more acutely unwell people in the intermediate beds, which is also helping get them out some of the high-intensity care placements. That journey is about 2 years in total from that first CQC inspection, the Newton assessment, all the way through to some of the frontline work that I've talked about there, which has happened in the last sort of 6 or so months. And Birmingham, for one, are very proud of the journey that they've been on. And in fact, the gentleman from the council, the DAS from the council, is speaking at NCAS on Wednesday of this week about his experience of the journey. And then from a system perspective, you'll notice that when you look at it from a financial perspective, by the end of this year, there'll be system savings of between about 15 and 21 million pounds for the whole system. And make no mistake, a significant part of that, obviously, is for the council. They've also had some amazing feedback. So they had a Integration and Better Care Fund review, and the feedback that they got from there is kind of, there's a couple of statements kind of summarised, but essentially The team that came in at the end of the summer, which was towards the end of the testing, said, well, the place is unrecognizable by comparison to where you were when you had the CQC review. And we've also had some great support from people from the NHS side and also from the Health Watch side who have personally come to see it for themselves in Birmingham. And just last week, Sir Robert Francis kindly came and we were able to show him some of the work that we had done and the contribution that Health Watch had kindly made to that. We're not going to go through all these, but Rich is around for the rest of the day, and so to kind of stimulate your thoughts on questions, I put those sort of learnings up there, which kind of illustrate that despite the fact that I've obviously stood at this session talking about a city council, that some of the challenges, certainly from our experience, are very, very similar at the county council level. Yeah, we'll be very happy to kind of talk to you about any of those items. And there's my point there about putting staff from different disciplines together does not just create the multidisciplinary working. Thank you.
So briefly to close, thank you, Andy and Peter, for your input. I think if the exam question at the start was, how do we make sure we make integration deliver improved outcomes rather than deliver integration as a means into itself, hopefully we've shown through a couple of the case studies that starting with the outcomes and then through communication, collaboration, coordination, the integration bit can start to take care of itself. And I think if you're wondering where on the spectrum you sit and sort of whether or not you're making progress in the right direction, I think the important question for me is, how do you find the mic in your system? How do you find the outcomes we're achieving for real people? And how do you get the real measure around that on a live basis so that every change we make, we can see the actual practical input that's having for patients, residents, and users, rather than just looking at the success in how organizations come together and form. So I think there's about 5 minutes left.
Thank you very much. And Pete, thank you, Rich and Peter and Andy. Lots of questions coming in on the technology system. I will take a couple of questions around the room, but we've only got about 5 minutes or so we're going to have to be very quick. So very first question is about funding, and excellent presentation, good focus on positive outcomes. To what degree, if at all, has the better working with health being aligned to a population health approach, and is there any evidence the integrated care system shifting resources upstream from acute into the community?
Yeah,
I think that's probably for you, Rich.
Yes, I think it's a very, very good question. I think one of the points, and Andy touched on it, is that through the work, obviously, there's a fortunate link between improved outcomes for individuals through the system and reduced cost. And where we find savings, and Andy mentioned some of the ones for Birmingham there across the system, we actually find that isn't just in health or just in social care, and actually there's savings on both sides of that fence. And so it isn't necessarily the case that funding has to be shifted immediately from one to the other, and progress can be made by looking within the existing sort of funding envelopes for organizations. I think that works up into a point, and obviously as that scales up into a larger picture and as demand pressures continue to grow, then that narrative may need to change. But as a starting point, at least there's opportunity to progress that just within the bounds of existing funding. Peter, I don't know if you have any thoughts on that.
I think there's more to go, I think, in terms of are we doing enough on prevention and enough upstream? I think the simple answer to that is no. So there's a long way to go on that. And I think there's the potential, given the increases in funding that the NHS is getting in particular, almost to look at how some of that funding can help support some of that early intervention and prevention.
Okay, and very related to that, what was the role of the Health and Wellbeing Board, particularly in Birmingham? Did it have a role? Was it involved?
So right now, from a point of view of the sustainability, actually, of the work, the Health and Wellbeing Board, from a governance perspective, oversee all of the activity. And then we created a governance system that sits underneath that comes through those 3 rings that I showed up earlier, and that includes the early intervention work. So mainly from a governance perspective.
Okay, I'm going to take one more from the pad and then I'll come to the room. So if you want to ask a question, get ready. We'll bring the mic. I think this is somebody that's maybe trying to look for a specific answer, but I'll ask the question anyway. And it relates to CCGs and whether you. When it comes to integration of health and social care delivery, how do you see the role of CCGs changing, And is there sufficient democratic accountability or oversight of them?
Who wants to take that one?
You might not want to answer the second one. We are in Purdah, so what about the first one?
Peter.
The changing role of CCGs.
So CCGs are obviously changing and they're being moved onto bigger footprints. And for Essex, that does pose a problem because we've got 3 STPs, so, which then cut across different counties. There's some opportunities, though, with fewer people to deal with. As currently I have 5 people to deal with. We might have 2 or 3, so that's one simplification. Secondly, as they go up, I think they're going to have capacity at a really local level to work with district partners, voluntary sector and council, so I think that's an opportunity. But I think the key is actually more about our work with the providers increasingly. That's where I see the great opportunity.
Okay, thank you. So I'll take any questions in the room if anybody's not been able to put it through on the app. Any questions? No? If not, then I'll take one last one from here, which came through very early on. So I will ask it, and it's from Peter Thompson. Are there any significant differences in DTOC rates between England and Scotland? And if so, why do you think this is?
So I can't answer the question specifically in terms of Scotland because I haven't the national work that we did as part of this didn't look at Scotland. What was interesting though and what was worth pointing out is that graph I put up where we identified that 27% in acute hospital bed didn't need to be there, that actually didn't correlate to the DTOC percentage. So when we looked on a trust by trust and an area by area basis, the reported DTOC figure didn't necessarily correlate to the measure that was resulted at from this work. And I think that what that says is actually that different practices and behaviours within individual trusts result in different DTOC reporting practices. And so that wouldn't surprise me if there was maybe differences more at national level as well.
Okay, thank you.